Hello everyone, this is Mrs. Korea. Welcome to week 13 lecture. We will be discussing about child with integumentary conditions and child with genitourinary conditions this week. Integumentary conditions, we will start with acne vulgaris. There is no specific cause known to this condition, and a proven factor is increased androgenic hormonal influence. The signs and symptoms, there are open comedones and closed comedones. The open comedone is the black head and closed comedone is the white head. And there is a possibility of inflammation too. And in the mild acne, the acne can be divided into three categories: mild acne, moderate acne, and severe acne. And in the mild acne, lesions are scattered, covering small areas with open comedones and closed comedones. And in the moderate acne, the lesions are more numerous, covering large areas, and there is open and closed comedones, and there is possibility of pustules. Those are the lesions filled with follicle cells, sebum, and WBCs. And in the severe acne, the lesions are much more numerous, covering larger areas, open and closed comedones with erythema and pustules, papules and pustules, and there is a possibility of nodules and cysts too. The care of acne includes assess the acne, clean and moisturize with water-soluble moisturizer. Mild acne, we can use topical acne medications with benzyl peroxide. Moderate acne, topical tretinoids, topical benzyl peroxide. And in severe acne, it's more intense treatment: topical tretinoin, topical or oral antibiotics if there are inflammatory lesions. Oral tretinoin, that is a very carefully prescribed one. They need to be enrolled in the federally mandated iPledge program, and they have to do a signed consent and monthly lab test and monthly office visits, and they have to do the pregnancy test before starting this medication and every month. So this is very important. Impetigo, often precipitated by insect bites or other skin trauma, most commonly caused by Staphylococcus aureus or streptococci, and it is very highly communicable with incubation period 1 to 10 days. There are two types, bullous and non-bullous. Signs and symptoms, it is found on and around the mouth. Lesions begin as vesicles or pustules. Honey-colored exudate, which is seen more with the non-bullous, and pustules, vesicles with a smooth, shiny appearance is seen in bullous type, and there could be pruritus. And the care includes prevent spread of infection to others and exclude school and public programs until 48 hours after starting antibiotics. Spontaneous resolution or topical antibiotics is sometimes used, like topical antibiotics such as mupirocin, and oral antibiotics for widespread infections. Herpes simplex, there are HSV1 and herpes simplex virus 2. The viral type 1, the most common you must have heard about cold sore is with HSV1, and HSV2, that's a viral type 2, is more common with genital herpes. The signs and symptoms are painful watery blisters on mucosal surfaces of skin such as lips, mouth, or genital area. Lesions appear after stimuli such as febrile illness, stress, sexual contact, ultraviolet light exposure. And the collaborative care is actually there is no cure. Medications decrease the length of outbreak and or increase the intervals between outbreaks, such as acyclovir. Atopic dermatitis, this is otherwise known as, the common term is eczema. The signs and symptoms are red raised rash that is pruritic and painful. The rash in infants usually presents on the head, face, arms, and legs. The rash in older children usually presents in folds of the arms and legs and occasionally on the eyelids and neck. And these rashes could be erythematous, itchy, and there could be irritated scaly patches. And the chronic skin changes can occur with like hyperpigmentation and lichenification, because it is very periodic, like they itch and then there could be like lichenification. The collaborative care is prevent secondary infection by using good hygiene, follow prescribed treatment protocols, maintain skin hydration, frequent monitoring, and rash assessment. Now we are going to move on to the genitourinary conditions. The first one is vesicoureteral reflex. So normally the urine flows downward from the kidneys, and in vesicoureteral reflex the urine back flows from bladder to ureters and sometimes all the way back to the kidneys, and this occurs at vesicoureteral junction. So the vesicoureteral reflex is a common cause of UTI in children. So whenever there is frequent urinary tract infections in children, you should suspect vesicoureteral reflex too. The signs and symptoms are: most common presentation is recurrent urinary tract infections. Flank pain, abdominal pain, and enuresis may coexist. Fever, nausea, vomiting. UTI symptoms, and the diagnosis is based on voiding cystoureterogram and by uses the radiographic contrast material and material observed reflexing back into the ureters and kidneys from bladder. The ancillary tests may also be ordered, such as renal ultrasound, nuclear scan, and intravenous pyelogram. The care includes treatment plan varies based on grade of the actual reflex. In most severe cases, surgical intervention is required, and care of non-surgical vesicoureteral reflex includes vigilance in preventing and treating urinary tract infections, avoiding renal scarring and damage, looking out for growth failure and hypertension. Care for child having a voiding cystoureterogram prior to test is identify patient using two identifiers, ensure patient has complied with dietary restrictions, obtain history and nursing physical assessment, including the lab work, vital signs, etc. And also with prior to the cystoureterogram, remove all external metallic objects, obtain list of current medications, determine allergies including reaction to iodinated contrast medium, assess substance abuse issues, instruct patient to void or apply clean diaper, ensure test is performed before and upper GI or barium swallow, and record last day of adolescent's menstrual period to determine possibility of pregnancy and have a legal guardian sign informed consent. Review the procedure with patient, like age appropriate explanation and with family, and then address the questions and concerns. And during the test, have an emergency equipment ready, observe standard precautions, place patient on examination table in supine or lithotomy position, collaborate with the X-ray technician to ensure a radiograph film is taken of kidney, ureter, and bladder so barium or stool does not obscure visualization of urinary system. Monitor patient's vital signs and for complications like allergic reactions to iodinated contrast medium, anaphylaxis, and bronchospasm. Then after the test, report will be sent to the healthcare provider who will discuss the results, instruct patients to resume the child's usual diet and medications as directed by the healthcare provider. Monitor vital signs and neurological status per institutional protocol. Notify healthcare provider if elevated temperature or abnormal vital signs. Monitor for a reaction to the iodinated contrast medium, and instruct parents to report symptoms such as fast heart rate, difficulty breathing, skin rash, itching, chest pain, persistent right shoulder pain, or abdominal pain immediately. And after the test, you also need to maintain the adequate hydration based on kilograms of weight, reinforce any information given by healthcare providers related to further testing and follow-up appointments, answer any further questions or concerns. Surgical management ranges from abdominal surgery to less invasive endoscopic surgery. Depends on unsuccessful previous treatments, and care of post-surgical patients include monitor intake and output carefully, maintain patient's pain control. And education and discharge instructions: educate family members about signs and symptoms of urinary tract infections, emphasize importance of medications in this chronic disorder, and emphasize importance of early identification of urinary tract infections and risk of pyelonephritis, and pyelonephritis causes renal scarring and damage. So we need to be careful in treating this to prevent such damages. Cryptorchidism. This is absent or undescended or ectopic testicles. Most common male congenital anomaly, and it is noted in 2 to 4% of all newborn males. May result from hormonal, anatomical, or chromosomal variations, and prematurity increases the chances of signs and symptoms. So a retractable or retractile testis has descended but retracts with exams and physical stimulation. An ectopic testis is outside of the normal pathway, that is in the groin or abdominal wall or in the perineum. And after 1 year of age, it is uncommon for the testis to spontaneously descend. And in 85% of the cases, the undescended testis is unilateral and usually on the right side. The diagnosis is based on patient's history, physical examination findings, and imaging tests. And gentle compression of inguinal canals should reveal palpable nodule in undescended testicles. The care includes counseling parents about surgery and benefits of surgery for infertility, because if it stays more in the abdominal cavity, there is possibility of infertility in the future. And emotional upset of increased lifelong risk of testicular cancer. The undescended testicle is a high risk for testicular cancer. The surgical management of cryptorchidism or undescended testicle is orchiopexy, and we need to explain on orchiopexy. And the surgical repair usually done at the age of 6 to 12 months. And general anesthesia and sometimes a caudal block given prior to surgery. It is minimally invasive, may involve laparoscope used to locate and pull down the undescended testicles into the scrotal sac and anchoring it there. The education and discharge instructions include it is the similar instructions applied to patient who has undergone orchiopexy as to patients with, same with varicocele or any other surgeries. Tell patients that despite surgery, boys with this condition have a risk of infertility as well as testicular cancer for life. The next condition is hypospadias and epispadias. They are congenital conditions, possibly genetic, characterized by an abnormal positioning of the urethral meatus. In hypospadias, the meatus is inferior to its usual position, or you can say the meatus is on the ventral side. So I try to, this is hypo and epi, you may always get confused. So I try to remember this way: hypo, high, ventral side, V. So high V is for hypospadias. And epispadias is the meatus is on the superior side to its usual position, and or superior position, or we call it on the dorsal surface of the penis. And surgical correction with possible penile urethral lengthening may be necessary. So don't confuse with these two terms. Find a way to remember it, which one is hypospadias and which one is epispadias. Okay. Okay, I want you to remember that. Then signs and symptoms of hypospadias include opening of urethra below the tip of on bottom side of the penis, and in this, like bottom side means inferior side or ventral side, and there could be incomplete foreskin. The curvature of the penis during erection may be a little different from the normal one, and abnormal position of the scrotum in relation to penis. And the epispadias signs and symptoms include opening of the urethra above the tip of the penis, that is the dorsal surface, and there could be change in the curvature of the penis and the urinary incontinence. Diagnosis is based on the patient's history and physical examination findings, radiography and ultrasound. The care include increased incidence in 1990s associated with the low birth weight babies and babies born to mothers who had undergone in vitro fertilization and had taken fertility drugs, and has a familiar risk. Assist parents in dealing with guilty feeling over possibly causing the disorder, and be prepared to counsel the parents because they are upset about congenital defect and the needing for surgery. The post-surgery, we need to observe for excessive swelling. Some swelling is expected, hematoma, and any purulent discharge. After the surgery, observe for fever, erythema, which may indicate possible infection, and indications of complications such as urethral fistula, stenosis, and return of meatus to original site post-surgically. It cannot happen rarely, and strictures at site of anastomosis. And instruct caregivers to have child soak in warm water for 20 minutes before surgical follow-up appointment to loosen the compression dressing. Education and discharge instructions include teach parents to watch for evidence of urinary tract infections such as fever, cloudy, foul-smelling urine, and hematuria. Inform parents that child may suffer acute pain related to incision, bladder spasms, or infection. The medication called oxybutynin chloride or ditropan is used to relieve bladder spasms. The next one is testicular torsion. I have included this topic because if you ever work in a pediatric office or in a pediatric ER, you will see this condition, and it is a real emergency. So because the surgical interventions must occur within 4 to 8 hour time frame, which is very important to remember this, from the onset of symptoms, or the patient risks the need for an orchiectomy, that is the resection and removal of the testicles. One, or if most of the time it's only one testicle is torsioned. The signs and symptoms in neonates, you may see that scrotum appears dusky and like a small solid mass when you palpate. Scrotal edema prevents transillumination, that is the inspection of testis by passing light through the scrotum, and minimal or no pain from testicular motion, that is in the neonates. But in older males, there could be severe persistent pain which may begin gradually. And the trauma or physical exertion may promote the development of testicular torsion, and there could be, like I explained, severe pain. And pain may be severe enough to awaken the patients at night and may prevent ambulation. So it's really excruciating pain. And fever, anorexia, nausea, and vomiting may be followed by this pain. And diagnosis is based on patient's history, physical examination findings, and Doppler ultrasonography. Upon physical assessment, one thing you will find is absent cremasteric reflex on the side of the torsion suspected. So how to test this cremasteric reflex? That is, when you see a swelling and pain on scrotum, so stroke the inner thigh of that side, and you will see normally if there is no testicular torsion, you will see that the testicles are taken up. So if you see that testicles are not taken up, that is absent cremasteric reflex. So that is a high possibility of testicular torsion at that time. So you can check the cremasteric reflex on both the sides, and in the suspected side, if that is absent, there is a possibility that you should really suspect that there is a testicular torsion. So in the care, you need to offer support to the patient and family about this emergency situation prior to surgery, and complete thorough nursing assessment and history. Ask about allergies, obtain medical orders, include pain medication, take vital signs, ensure patient is not taken anything orally, that is NPO status, because we may have to do the surgery as soon as possible, and have surgical consent form signed by the parents and witnessed by the nurse. Keep patient calm using distracting techniques. Post-operatively, we need to assess vital signs, manage pain, give fluids as tolerated, track intake and output, give emotional support until discharged when stable. The education and discharge instructions include teach parents the importance of assessing surgical site, recognizing signs and symptoms of infection, adequate hydration, and use loose fitting clothing, and coming in for follow-up appointments. That is all about this week's topics, and thank you for listening. Have a good day.